planning and implementation. This advisory committee will provide a liaison with our Health Services Committee and help implement the previously described survey. The advisory committee will be limited to 12 members, but will be anxious to receive input from as many residents as possible. And I know you're not shy about giving input. The following residents have agreed to serve. Jay Levy and Jane Wojcik are co-chairs, Carol Murphy ex officio, Mary Franz, Karen Pridham, Toby Cohen, Paul Godis, who was invited and has accepted, wonderful, Alex Dove, Marge Tobias, Jean Silverberg, Marion Beachley, Marge Engelman, and Connie Bacher. And now it's back to Jane to talk about the components of the healthcare project.
Well, thanks, Tim, for coming and giving us that nice send-off and encouragement. We are going to be working hard to develop these proposed components. And the components, as Tim said, are possible components. These are components which have been identified as likely to meet the goals of the project, which would be to fill a gap in healthcare at Capitol Lakes, but also to reduce costs of Medicare and healthcare in general, and also to have a partnership with UW. So as you see, as we start to talk about these components, they all have to meet these three criteria. The proposed components are online geriatric education for providers and residents, the pharmacist review of resident pharmaceutical regimens, and of course these will all be with the permission of the resident. It just isn't going to be forced on you. Advanced directives education, of which we've had some really wonderful progress so far. June Blanchard several years ago started on an initiative to have everybody have advanced directives, and more recently Margaret Barker has been leading a group to be sure that there is nobody who doesn't have advanced directives because they don't have people to work with in terms of serving in one form or another to help have the advanced directive. We also hope to expand geriatric primary care providers by the projects that we involve with training. We think it's very important to have more utilization of electronic health records, so we'll be working to see how we can expand that while maintaining privacy of all of us. There's also been an initiative for respite care for independent living residents. Some of our independent living residents have a significant other who needs to have more attention, and the spouse needs respite care, so we have some proposal for that. And then the final one is general prevention education for seniors. And that's a very broad one, which includes being sure that everybody is well informed about steps they can take to help prevent having an incident later on that could have been prevented. So with that, we need to realize that with those components, that there are people who will be working with each of these. And of course, a key person for the online geriatrics education is our own Dr. Irene Hemrick, who is the chair of the teaching nursing home here at Capitol Lakes. Thanks, Irene, for coming.
Thank you for the introduction. I moved to Madison 6 years ago and developed the teaching nursing home here at Capitol Lakes 5 years ago. And many of you have already attended my lectures that are happening 3 times a week on Monday morning, Wednesday morning, and Friday afternoons. And I will have to dart right after my speech to get to my lecture that starts at 1:30, and today is going to be on pharmacology. So if you'd like to come and join us. But I'm moving to having all those lectures posted online. I give 32 lectures on a rotational basis. 9 of those are currently posted on YouTube that are freely available to all of you. And I hope to get to post all 32 of them, and as I add more lectures, even more. So since I have started the teaching nursing home, I have added more and more interdisciplinary learners to our group. We started with doctors of family medicine internal medicine and geriatric medicine, and also added medical students. And we've also added nurse practitioner students and PA students. And I hope to also get, and I teach occasionally pharmacy students, but I hope to also then expand to other disciplines beyond that. As part of my role in the teaching nursing home and in the expansion of nursing home coverage in Madison, I have also worked and expanded the nurse practitioner coverage for the nursing home. And when I first moved here, we had 3 nurse practitioners that were going to 19 different nursing homes. We now have 10 nurse practitioners, and we have 1 nurse practitioner at Capitol Lakes who covers UW patients on a daily basis. We've also included the Meritor patients, and we're working with Dean as well. They also have a nurse practitioner coming in. I have also then taught the nurses here about hypodermoclysis. That is a sub-Q infusion of fluids so that patients don't have to go to the hospital for their care in case they get sick. And last night I ordered another liter of fluids, not via IV, but via hypodermoclysis, which is actually safer for older adults. And this patient did not have to go to the emergency room. So I have several different things going on to teach not only the interdisciplinary learners in my group, but also the staff here at Capitol Lakes. And we're hoping to expand with the nurse practitioner program to assisted living as well, but we're just doing one step at a time. For the videos, after they are recorded online, you're able to review them at your own pace. You can slow them down and rewind them. But we're also going to continue with weekly grand rounds. Currently, I have lectures 3 times a week, and you're welcome to attend them at any time. But we're going to expand that then to a weekly grand rounds and possibly have that here to where you can bring questions in and we can discuss cases and include the learners, but also you. And with that, I will turn that back over to you.
Thanks so much for including us in your schedule, Irene. I know you're very busy these days. Okay, well, the next component is pharmacist review of resident drug regimens. And we have here somebody from the pharmacy school, and I'm sorry I didn't write down your name.
It's all good. It's all good. My name is Mara Kieser. My nickname is Marty, and welcome to everybody here. It's very exciting, and I want to say thank you to Dick for allowing me to be a part of this whole thing. But my background is I'm a consultant pharmacist, and what I do is I specialize in reviewing patients' medications list, and I look for drug therapy problems. How can we make this better? So we're looking for ways to improve it, whether it might be identifying drug interactions or when the medications are actually given, or answering questions, doing education, or making sure the patients understand how to take these medications. So looking at it from a lot of different angles. And that's what I do in the nursing home. I also, for a bit, I was also over at the assisted living, and I would be doing their chart reviews. Again, looking over all the medications for each of the residents and making sure we're identifying any drug therapy problems, or if there's any adherence or questions, drug interactions, and making sure then we follow up with the healthcare provider to get those corrected. And so, what the vision is that we would be able to offer those services of where we would do a profile review looking at all the medications that a person takes, and again, making sure that the medications are doing the best for you, like checking for those drug interactions, making sure that the medications are being taken correctly at the correct times so that they can do the most for you and hopefully minimize any side effects. And so the goal will be then to set up a time, and I know Tim is allowing us, and again, these are all baby steps. We're just in the starting position. But the goal would be then to have an opportunity where if you're interested in coming to have myself or pharmacy students, I have one here right now, Julia Barnes, and so we would be doing the medication reviews, and we would look over all the medications and talk with you about it, you would have the opportunity to ask us questions. If there's something you might not understand about a medication or like more information, we could do that for you and then be able to give you information back. And again, looking for the best way to take your medications that make it best for you. And so on this slide, we'd have, as I said, improving medication scheduling, adherence, limit drug-drug interactions, and if there's anything that we needed to talk with you about or your healthcare provider, we would work with you and also then check in with that healthcare provider if we needed to address any concerns that might be brought up as we reviewed those medications. So we would have pharmacy students and also other learners, like some of the medical students, who would then also see what pharmacists can do, and so that they would learn to work together so that when they're prescribing, they truly understand how the patient is going to end up taking that medication so that they have a better understanding. Yes, a question?
Are we supposed to be able to read the screen?
I don't know because it's not very readable. So I'm thinking those might be in the handouts because it's really hard to see in the middle. I don't think you can see that with the white. Oh, questions at the end. So that's what's going to be in the works, is where we would be able to offer this service where you could have your medications reviewed by a pharmacist and the pharmacy students, and hopefully we would make sure that your medications are working the best for you. Okay.
I'm sorry, we weren't very clear about questions at the end. I think that probably is a very good idea. We didn't have a chance to get set up with Jay Levy having the mic and running around so people could hear the question. So until we get that really organized, we'll be sure to repeat the question in the future. And the other thing is we will try to hold the questions to the end. And I think now we're working on trying to get more contrast on the slide. Dick is getting in place because he is going to be doing the next presentation. The next presentation was to be done by a professor from the School of Social Work, but that person is in California giving a paper, so she was not available. So now Dick is next up with the rest of the components.
Okay, thank you. Can you all hear me? Is the microphone working okay? Well, that's great. Let me just make a couple comments before I go ahead and talk about the other components. I think it's important to recognize that everything we're talking about is a proposal. Nothing is a done deal. We hope that the first two things that you heard about, the interprofessional education and the pharmacy program, we can implement very soon. The following things that you hear about, it's going to be more down the line. The third thing, which I'm about to talk about, will hopefully be the next thing that we can implement. This third area relates to advanced directives. Originally, with the Professor Tracy Schrepfer, who is head of our geriatric social worker group at the university, was going to be talking to you today, and she was called to attend a meeting in Washington today. She is the director of geriatric social workers in the country. So she's really a very perceptive, national-based person who's very interested in this program and who feels that it has tremendous potential. Now, so what I'm going to do now is just briefly pinch hit for her in terms of component number 3. But before I do, I also want to emphasize to you that all of these components relate to Medicare. As you all know, with the Trump tax bill that was just enacted, we are going to have a tremendous deficit in this country, by probably another $1.5 trillion. And there's going to be a lot of activity to try and reduce the cost of Medicare. And what we are hopeful is that there can be ways we can develop to constrain the cost of Medicare, but still maintain high access to Medicare and superb service. And so that's what these components are about. They're about people living in continuing care communities, continuing care retirement communities, and we're going to see more and more continuing care retirement communities in this country because, number one, of the mobility of our society, number two, because of the necessary two-wage earners in a family, and the general feeling is that groups of Capitol Lakes type communities are going to be growing very substantially in the next few years. Now you might ask, everybody can't afford Capitol Lakes, and are there other approaches that can be used in terms of the type of things we're talking about, where the majority of people who are less affluent in our society can take advantage of? And we hope that what we're developing here will be a model for other programs, particularly in housing developments and other major programs where people can stay in their own homes, and we can train home caregivers who implement many of the things that we're talking about today in terms of the components that we're covering. So I want you to understand that these are projected components for here, things that we've kind of dreamed up as a group, and we hope that we can implement many of these and that this will be a model for other places, not just affluent people in our society, but all members of our society. And we're very hopeful that the partnership that we're developing with the University of Wisconsin, and we'll talk about that in terms of the number of schools and colleges involved, and also we hope to develop a partnership with the Madison College for some of the things we're talking about. So this is very exciting. This is exciting. This is the future. This is 21st century medicine. You all need to understand that the old type of care, in terms of your doctor being your only caretaker, those days are going to be over. We're now approaching what we call team care. And your primary care provider will utilize a team of nurse practitioners, social workers, PAs, physical therapists, occupational therapists, all these people who can help provide the services that your primary care doctor in no way has time to do. So that is what this whole program is all about. Now, let's go on to component number 3. I think almost all of you probably have advanced care directives. And June Weisberger Blanchard has been working very hard the last few years on this to try and encourage people to all have advanced directives. The problem, and you'll notice in the handout, there's enormous detail about advanced directives. I did that intentionally because I want you to understand how complicated this area is, and that there are 3 different types of advanced directives, and that there's a great deal of work that has to be done on the part of everybody to make sure that you have the advanced directives that you really indicate what you want in life and what your family wants. And my bet is that most of you who have advanced care directives, they are probably not terribly usable and effective because they do not really get across what you and your family really want. So what we hope to do is have an extensive program of education for all of you so that you can learn what it is that you need to do and how to implement what you really want in terms of advanced care directives. Now, the question is, and we'll talk about this in a minute in terms of what you do with your advanced care directives. Where are they? I'll talk about flash drives in just a minute when we come to another component. But that, I hope that you can read that to give you some idea of how complicated this area is and how much work we need to do. And I hope that our medical social workers, and I hope to involve law students also, because this is a great learning opportunity for law students. As you all know, doctors are provided by Medicare once a year reimbursement for talking to patients about advanced care directives. I can tell you that your doctor knows virtually nothing about advanced care directives. And the problem is our medical students don't learn anything about advanced care directives, and we want to do something about that. But that Tracy Schrepfer tells me that National Medical Social Workers Group was very concerned about the Medicare law that was passed because it's not going to be very effective. Well, number one, most doctors won't take the time to do it right. Number two, they don't really know how to advise you very well. So that's why we want to have this thing. Okay, the fourth component is, if I could have the next slide, please. As I think many of you know, there's an extreme shortage of geriatricians in this country. I can just as an aside, I can tell you that in my career, I'm a kidney doctor and came here to start the kidney transplant program years ago, and then I was the founding dean of our Milwaukee campus. But when I came back here, I became increasingly interested in health policy. And I spent a year with Senator Ted Kennedy on sabbatical and wrote a training grant law that is still in effect, which funds the training grants for geriatricians. And we thought that this would be very helpful in the mid-'80s. It has not been helpful. It's worse than ever in terms of our severe shortage of geriatricians, which we face in this institution and all over. And it does not look as though it's going to get a lot better in the near future because our medical students and medical residents are much more interested in things that have better reimbursement. And interestingly, a geriatrician makes approximately $30,000 to $40,000 a year less than a primary care doctor. So that's what we need to deal with. And how do we deal with that? Well, the first thing is that, first of all, we feel that everybody over 65 ideally ought to have a geriatrician as a primary care doctor because geriatrics is a different specialty than general primary care. You all know that we, as seniors, have very unique medical needs. And it's many doctors in practice are not familiar with these unique needs. So we feel that because we have this shortage of geriatricians, the key for that is training many more geriatric nurse clinicians. And we're trying to talk our nursing school into greatly expanding their program to do this. I've worked closely with the nursing school at Duke, and they have a wonderful program that does this. And we hope that in the next couple of years, we'll see a lot more geriatric nurse clinicians in this institution. And nurse clinicians, nurse practitioners can write orders. They can function quite independently. And as far as I'm concerned, I would be delighted to have a nurse practitioner, geriatrician nurse practitioner as my primary care provider, as long as he or she interacted with appropriate subspecialists. And the way we interact with subspecialists these days is electronically through electronic consults. You don't have to eye your subspecialist in many cases, just through the computer with computer prompts to the primary care provider. It can be very effective in implementing subspecialty advice. Okay, now the other providers that we are very interested in, who I think are going to be extremely important, are physician assistants. Physician assistants have a little different culture than nurse practitioners. Nurse practitioners like to work on their own, just interacting with doctors, but working on their own and writing their own prescriptions. PAs, their culture is to be the extender of the doctor. And what we'd like to do is to encourage the PA program here to turn out geriatric PAs. Now, those of you who have been hospitalized, any hospital in Madison, you know that your doctor doesn't take care of you in the hospital. The person who takes care of you is a hospitalist, okay? What we want to do is develop a system where we have a PA hospitalist at this continuing care retirement community. And we think that this ought to be the case at all continuing care retirement communities. So that when you fall, and I should tell you that even if you don't have the 3 predisposing things to falls, 10% of you will fall in the coming year. It's a very common problem. When you fall, what happens now in this institution, you call the front desk, And most of the time, they will call the EMTs. The EMTs will come rushing over, and most of the time, no matter how you fell or anything else, they will take you to the emergency department. And when you end up in the emergency department, the chances are you're going to be admitted to the hospital. And many times, this is inappropriate. If we had a PA here on the scene who could immediately evaluate you, we would eliminate a lot of this and save an enormous amount of money and unhappiness in terms of being taken away from your own community. So that's something that we want to develop as rapidly as we can with the PA program at the medical school. And that's going to take a year or two, changing their curriculum and getting people involved here. But we want to have PA students. We want them to be here 24/7, every hour of the day and weekend, so that anytime any emergency occurs, it can be evaluated immediately. Their faculty can come in very quickly if they need added advice. They're going to be advanced students, but if they need advice, they'll have immediate faculty supervision. And some of the time, we will avoid having to call the EMTs. I hope much of the time. As you may be aware, the EMTs love it when we call them, because the more we call them, the more we increase their budget, the more people they can employ, and they also, I believe, charge Medicare for the visit. So that's a quick rundown in terms of why we want to expand geriatric expertise here. Okay, number 5, the next slide. Here, the importance of resident electronic health records. It's important when something happens to you, or when you consult with the pharmacist, that we have access to your medical record, and at least the list of your diagnoses and the drugs you're taking and a major summary. But if you're like I am, you don't want to share this with everybody in the world. There's a lot of stuff these days about being very careful about sharing medical records and people seeing them who shouldn't see them. So that what you see in my hand here is a flash drive for a computer. And what I hope we can do is convince most of you and your doctors to put a summary of your medical record and your drugs on a flash drive, so that anytime anybody needs to see you, they can immediately plug this into their computer and have all the information on you available to them. But you would hang on to this. You would either wear this on a tag around your neck, or you'd put this on your door, or wherever you're sure that nobody could have access to it. But this is a way, and this will take a while to do. But to do this, we have hired another program director. I should point out that the program assistant who you met when you signed in was Bethany Avis, who's been a tremendous help to us, and she's going to be administering a lot of the schedules of the students and doing a lot of the things. The second program assistant is going to be Grace Compton. Grace has worked for Epic for the last 6 years. I think you all know what Epic is. Epic is probably the world's largest medical record company, which is located in Verona, Wisconsin. And Grace doesn't want Epic to be the rest of her life. She graduated from Middlebury about 6 years ago. She's a very bright young lady who is now to be a physical therapist. And she's starting the physical therapy school next week. She will work as a student about 30 hours a week, and it's going to be her job to work with us to develop electronic health records for everybody if people want them. And we hope that most of you will see the wisdom of doing this, and we hope that we will get a grant to do this. Now, while I'm at it, let me say a word about grants. Everything we're talking about is dependent upon external funding, except maybe the first component, the lectures. The external funding, we hope, is going to be quite available these days because everybody is very interested in this, particularly with the problems with Medicare. And first of all, the medical school has a large fund which really fits nicely with a lot we're talking about. There are many other foundations like the Macy Foundation, the Hartford Foundation, Robert Wood Johnson Foundation that are also very interested in what we're proposing. So we're going to be very busy in the next few weeks trying to interact with all of you. And we will have, I'm going to try and end this fairly fast. We'll have a discussion period at the end of this, our presentation, to start dealing with all of your questions. And I'm sure most of you have many questions. We had a wonderful meeting of the advisory committee last night, and some very good questions came up. And I hope that that narrative that you all received a copy of, we intend to revise that. That's a first draft. We intend to revise that and answer a lot of the questions that have arisen regarding this program. The idea is that we want to get this done by March so that we can tell the outside support people what we're up to. And it will be important to carry out a survey of every resident that we can possibly get to complete it, to get an idea how residents feel about the program. Because all of these granting agencies, that's the first question they will ask is, do the residents want this and will they participate? And that's what we have to determine after what we're going through with today and the discussions that we'll have in the next week or more until we finally come to the point where we complete those surveys. Okay, now, so we talked about, we pretty much covered what's going on here. Next slide, please. The next thing is respite care. And we have had many situations in the last few weeks arise where people would have done beautifully with respite care, but they've had to go over to assisted living because they could no longer stay in their independent living setting. Respite care involves 4 to 5 hours a day of relief for the individual who's caring for the person in independent living. And we hope that that could be done in space that we hope we would get on 2C. And so that people could wouldn't have to go across town for respite care. They would get it right here. And we would hope that occupational therapy faculty and students would be in charge of developing that program. And we think that this will be a very popular and useful program, again, which will be strongly supported by foundation support. The next slide, please. And the next thing relates to prevention. And we feel that this is an extremely important way of modernizing Medicare service delivery. And I put down 9 areas, but there are other areas in addition to this. But in your narrative, we talked about all 9 areas. Immunization, it's very important that all of you, and I hope all of you, have had flu vaccine. Those of you who have had shingles vaccine, you must know that it's only 10% effective at our age. But next week, in the next couple of weeks, a new shingles vaccine is coming out that's 90% effective. And that will be available, and hopefully Medicare will pay for it. It will be coming out probably, I think in a couple of weeks is when it's scheduled to come out. And I'm hopeful that pharmacies will provide that. You won't have to go to your doctor to get it. Okay. Also very important is exercise. It's been shown that exercise significantly retards Alzheimer's disease. And in terms of other forms of dementia, we know that exercise can be probably more effective than drugs at this point. The drugs are really not very effective at all. And what we hope is that our physical therapy students, and we now have 1 physical therapy student here already, but we have an excellent physical therapy department here, which will be tied in with the medical school. And we hope that physical therapy people will evaluate residents to see how much exercise you can safely do. Because it's nice to tell people to exercise, but we don't want people to exercise more than they can safely do. Okay, another area is nutrition. And this is where Jane comes in, and the nutritional science people. We hope to have nutritional dietetic interns here, and your diet is fantastically important in terms of your health. And it's very important also in terms of the second to last thing, in terms of blood pressure regulation. Blood pressure regulation is extremely important in terms of falls. It's extremely important in terms of a lot of other things. That happens to be one of my areas of interest and expertise. And I can tell you that there's a lot changing in terms of blood pressure regulation, and it's something that we need to teach people how to take their own blood pressure or else have somebody take it for them very frequently. So we know what the oscillations of blood pressure are. So we know who's getting dizzy because their blood pressure is not high enough, not because their blood pressure is too high. Okay, other things, we talked about falls, dental hygiene. How many of you see a dental hygienist twice a year? Raise your hand. Well, that's very nice to see. I didn't think it would be that good because dental hygiene is very important. Inflammation of the gums is very important in terms of your general health. We know that inflammation of the gums causes coronary heart disease. So that what we hope to do is equip a dental clinic here and have dental hygienist students from Madison College along with their faculty providing dental hygiene for people who desire it, who cannot get it otherwise. And that would be available here, hopefully. And we have an excellent dentist who will administer the program for us, who runs the program at Oakwood right now. He is a superb dentist, probably one of the best dentists in town. A senior person at the dental physician group on Whitney Way, and he's willing to be available to come and do dentistry work here for people who might need it, that the dental hygienists feel need it, rapid care. So that's the other thing is sleep disturbances, bladder and bowel dysfunction. These are things that can be we can very much educate people about, and then finally cancer screening, which is going to be increasingly important. People in their 70s, whether we all hate to have a colonoscopy, and right now I think you're probably aware that with the new Cologuard technique, you can avoid colonoscopy in many cases if you have a negative Cologuard test on your stool. And another thing that we're very concerned about is skin cancer. Some types of skin cancer need immediate attention. Basal cell skin cancer, the dermatologic surgeons are making a lot of money taking off basal cell cancers, which are like prostate cancer in men. They need to be watched. People don't die of prostate cancer usually, or basal cell cancer, they die with them. And we're doing a lot of unnecessary stuff that's costing Medicare a lot of money right now. So these are things that we're very much, next slide please, very much into. What we have had substantial resources to start this program. We have some seed money that's been available that's allowed us to hire people to help us. We have excellent potential for sustaining support from grants, which I mentioned. And we have some space already, and we're going to be getting hopefully more space on 2C and the small apartments that are difficult to rent. And hopefully we'll get some overhead from our grants to pay for that space, and we'll be able to have some real facilities like the pharmacy facility and even a geriatric clinic eventually on the 2C, where there are currently some small unoccupied apartments. Next slide, please. Now, in terms of the people who are involved, there have been a lot of people who are contributing their ideas to this, just to give you some idea. Who they are, Irene Hamrick, who you've met and heard from. You've heard from Mara Kieser, Tracy Schleffer. I've pinch hit for her. Edmund Ramley is a systems analyst who's helping us devise the survey and making sure we have a good survey. Steve Barzy, I think some of you know, he runs the training program for our geriatric group at the University Hospitals. We have probably, if not the best, one of the best geriatric units in the country, if not the world, here at University Hospitals. It's a superb unit. Steve Barzy does the training. He visits here about once every 2 weeks and is very enthusiastic about this program. Some of you know Alex Eastman. She's also a geriatrician. She's in charge of a medical school geriatric program, and she will be having third-year medical students under her supervision rotate through and come to our grand rounds, and possibly some of you will be able to give them tours of the facilities so they learn about continuing care retirement communities. Pat Remington is our Associate Dean for Public Health of the UW School of Medicine and Public Health. Pat runs our preventive medicine program. He's very much involved and very enthusiastic and has helped develop the prevention things. Jeanette Roberts is the former dean of our pharmacy school. I had a good talk with her the other day, and she is very enthusiastic about the program and is prepared to consider this as the community campus of her committee for interprofessional education of the medical school. And so that this is going to be very important in terms of teaching the team of people who will be available. And then Aaron Friedman is very interested in this. Aaron is the former dean of the University of Minnesota Medical School. He just retired. University of Minnesota has been in the forefront of interpersonal education, and he developed a lot of their programs. He is retired. He lives a couple blocks away from here. He is going to be very active and will continue to be active. He's about 12 years younger than I am, so I hope we have some young blood coming on board. Next slide, please. And then you met Beth Neves when you came in at the table. Beth has been extremely helpful. I talked to you about Grace Compton, who's our student from EPIC. And then number 3, you'll detect a little nepotism here. You'll recognize the name. That's my granddaughter, who's very adept at recording videos and editing them and posting them. She does that as student employment now for the extension, and is a senior person there who does that for them and is very good at it. Next slide, please. So that in looking ahead, as I mentioned, we view this as we hope this will be a community campus for interprofessional education. We hope it'll be a model upon which we can build other things across the country. And I can tell you that the Pacific Retirement Service is very interested in building partnerships with universities, and we anticipate that they are going to be very excited about this program. We talked about Medicare innovations, and we've mentioned our current Capitol Lakes gap. What I'd like to point out is the Capitol Lakes, I think, is fantastic, and it is a superb continuing care retirement community. And what I'm saying is there are a few things we can do to make it even better here. And to make things even better for you, I can tell you that there's the outstanding community, I think, in Wisconsin right now is St. John's in Milwaukee on the Lake. That has attracted a very influential group of people in Milwaukee to live there. And I'm very familiar with their programs because I know the person who developed it. And they're thinking about a lot of what we've presented today. They're struggling on how to do this. So that I think other places are going to be very interested in what we're doing. The next slide, please. So that really what we have is we've listed the 7 components that we've talked about. And you can't see this slide very well, unfortunately, but what it does is the X mark is the schools that are involved in each component. And we've talked to virtually all of the schools and colleges involved, and as long as we get support for the faculty, because they can't do it for nothing, because they have other things that they're great other priorities. But faculty will go where the money is. And if we get outside support and money from grants, I think we can get some very good faculty to work in this program and supervise the advanced students that we're talking about. Next slide, please. And this is, we're developing a couple of surveys. I won't go into this because we're going to use all of your advice in terms of developing these surveys, and I hope we can make the surveys we have even a little bit better so that they're all intelligible and so that we can get a very broad response from residents here to indicate to granting agencies what the interest here is in doing this. So it's 1 hour, less than an hour. I'm going to stop here. And we have a panel of people. We're going to ask Marty to join us up here. And we're going to, let's see, we have, okay, Irene had to leave. So we'll have 3 people here. And I'll sit over here in terms of moderating the panel. And Jay Levy, who's the co-chair of our resident advisory committee, is going to take a microphone and provide the microphone for all of you to ask questions, which we hope that the panel or other members of the advisory committee in the audience can answer. And so we can begin to fill you in, because this is a very complicated deal and there's a lot to think about and a lot to learn here. But I think I have every confidence that you can do it, and that we can together as residents implement this program and really make Capitol Lakes even more superb than it is right now. Okay, so Jay, if you could take a microphone and go around to people. Thanks. We're all set.
So are there questions?
I'm gonna sit here. I'll sit here and you can. Yeah, okay.
Thanks for everything that's been done so far and all the thinking you're all putting into this. My question is about terminology. Both Tim Conroy and Dr. Hambrick referred to the nursing home at Capitol Lakes. I really don't know what that is. We have the health center, which the community thinks of as, the wider community thinks of as a rehab center and offers skilled nursing. We have assisted living, we have memory care, and we have the physical therapy department. What is the nursing home?
Okay, do you want to repeat the question first?
Yeah, well, I don't think we need to repeat it. She said it on the mic. The question is, what is the nursing home referred to by Tim and also Irene Hamrick, Dr. Irene Hamrick? And they're talking about the health center.
You know, maybe I could respond to that, you know, and then let Carol respond first in terms of...
The idea of nursing home is an old appellation for what we're these days calling the health center. So the two terms are the same. Health center and nursing home are equivalent, same thing. Skilled nursing home, yes.
Okay, if I could mention, the second floor of our nursing home is transient, if people usually 30 days or less, covered by Medicare. The third floor is people who live there for their continued care. So that's what the health center is those two floors, the second and third floor. The terraces accommodates assisted living and memory care. And I think most everybody will understand that. We feel that we hope that we can interact with people in assisted living, and for those who are able to, understand this and deal with this, we hope we can deal with them and explain it to them. In terms of the nursing home, it's not appropriate that we interact with the people there because it doesn't really refer to them.
What are you talking about when you say nursing home then?
Pardon? Okay, now let me point out to you, in the nursing home, the nursing home is a superb nursing home. It's one of the best in the city, and the thing is, the people who are in the nursing home, if people are able to deal with this, and if they want to, then we want to be able to explain it to them. But many of the people in the nursing home is not. Many of the components we're talking about are not relevant to them in terms of prevention and the other things that we're talking about. The things that are relevant to them we'll be anxious to explain. But I think the key thing in terms of trying to survey the residents here, the key thing are the people who live in assisted living, the Heights, and Main Gate. Those are the key people who we have to determine what their level of interest is.
So
Okay.
just to clarify, the reason that the nursing home came up is because that's where Dr. Irene Hamrick is currently practicing, and that's where I'm currently practicing. I'm a consultant pharmacist for the skilled nursing facility, but the plan then is to expand out services for independent living. I am also a faculty member over at the UW School of Pharmacy. So that's the connection, and that's where that word came in.
And you're using that old term, correct? Why?
I'm an older person, and when I started, I've been at the skilled nursing facility since 1999 here. But it's the health center, so if that's the preferred term, we'll use that. So the health center.
Terrific.
The expansion of the services that you've identified are really exciting to have them into the into the independent living. And the way you've outlined like PAs and nurse practitioner, geriatricians, et cetera, all of which could really be a wonderful addition here. There's another thing that I'd like to raise as a gap here, which may have been identified very early on in the presentation when there was something about progressive patient care. Progressive independent living. Historically, what has happened is that assisted living units are entirely separate from the independent living units. There are some facilities here in Madison that are now combining those so that you can continue to live in your home in independent living and still have assisted living resource. I think it's neat that you're going to have a PA always on duty 24 hours a day. I think that'll be a wonderful improvement. But I'd like to see as a gap to be explored whether or not here, without any additional building costs, so the return on investment would be very good, to be able to have the combination when needed of independent living and for a person who may be living with a partner there in the room, assisted living as well.
You raise an excellent point, which I have discussed with Tim Conroy, and he is very much in agreement that we want to keep residents in their apartments as long as possible and provide the type of services you mentioned, if at all possible. And this is one area where having a lot of geriatric nurse practitioners available who could be primary care providers would be great. Because if these people had a geriatric nurse practitioner as their primary, that person could visit them in their apartment. They would not have to leave their apartment to see their primary care provider. And so we think that home visits are very important. We also hope to have a geriatric clinic here like Oakwood has. But the point you raised is key because, of course, it is very difficult when a spouse is living one place and the other spouse is living someplace else.
Could you give us an optimistic estimate of how long before this program could be essentially implemented?
Pardon me?
Could you give us an optimistic estimate of the timing of this program?
The timing we'll know more in the next few weeks.
Well, the first three components.
Yeah, right. The first component we can implement in the next few weeks.
In fact, some of it's already been done, right?
Yeah, because a lot of those lectures, most of those are available, and it's just a matter of recording more of them. Some of them are recorded already. The last page of your handout indicates the ones that you can actually follow that link on your computer and access those lectures right now. And so we hope to implement that soon. The pharmacy component, we hope, is the next one, and we hope that we may have some interim support to at least get that moving and get that going. Yeah.
So we would like to do some kind of pilot and just to see the feasibility about the whole process, but we're looking at doing some things this spring semester. So like probably in the next couple months. My goal would be to get some of our pharmacy students who would be interested in doing some of the chart reviews with me and then meeting with the residents here, patients here, members here, and then being able to start. So some of the first ones, we'll see how it all works and making it smooth. And then maybe in the next semester to be able to build a clerkship rotation so the students then just keep coming.
I think a really important point and speaks to why you're all here today is the progression of this program and the direction of this program depends on what it is that we as residents want. I'm getting a really strong sense of a commitment to base this on a bottom-up process, that it's going to be built on what it is that we want and need. And in that direction, the Health Services Committee, which I chair, one of its major focuses is going to be on supporting this and on supporting resident input into how this all goes. So in that direction, there's going to be a survey in the next few days or week, and it's going to be really, really important that people give us the feedback, because how this all rolls out is going to depend on what we hear from you. So not only you that are here, but people that you know, your neighbors, your friends, and so on. So I'm just making a pitch for people to fill out the survey.
I would like to talk about the survey and about the people. I believe that your greatest obstacle, your greatest challenge, is communicating what you said today in very clear terms, especially to people who are not here. Now, all of us on every floor in Capitol Lakes know there are people who have difficulty seeing, difficulty hearing, difficulty moving, difficulty going to things and attending things. And I'm not saying this in a jocular way, I'm saying it in a very serious way. So before you go ahead with the survey, I beg you to take a look at Capitol Lakes, look at its residents, and how can you establish some sort of approach or network where every person in Capitol Lakes has someone who will call on that person, or set up a series of floor meetings, and at the floor meeting have an excellent presentation followed by a little discussion of a survey, so that you bring in people who simply won't read these documents and understand it. And if you want to have great participation in order to apply for grants, then you've got to get it. And getting it won't be easy, but I think it's your first challenge.
Actually, in our meeting last evening, we talked about ways to improve the response on the survey, including going one-to-one with residents, not just laying it out there and saying, send it back, but going out and getting it, talking with each resident about what the program is, explaining it, answering questions, and then getting them to fill out the survey. So we're taking a very active approach to getting the survey filled out, not passive.
I might add that I've talked to Mary France, who's on our advisory committee, who's also very active in Connections. We've talked about integrating the activity of Connections with the third component of this, with the medical social workers, so that one of the points you raised really refers to Connections and what's been accomplished so far with Connections.
My problem is this. We are here 7 days a week. We have health problems 7 days a week. We are taken care of Monday through Friday. What happens Saturday and Sunday? I need eye drops. Fortunately, Bright Star takes care of me Monday through Friday. I can't tell my eyes, hold off until Monday. We'll start again Monday. And can something be done for us on Saturday and Sunday, health-wise, with the people that we need assistance from?
Well, that's one of the things that we're very concerned about. And I think that what I hope that we can have 24/7 coverage by PAs. How soon we can accomplish that, I'm not sure, but we're going to work very hard. But what you're talking about would be wonderful if we had a PA here at all times to provide the services that you're missing on Saturday and Sunday, as well as the other things we talked about. And also, we are very concerned that maybe we could do more than is available right now through the Bright Star Nursing Facility. The services are somewhat limited available there.
Dick, when you hold that, it rumbles.
Oh, okay.
So maybe what I should, do you want to
Okay.
hold, are you finished?
That's right.
Okay. Other questions? You know, I think we've heard some really good points today, and Jay Levy promised he was writing down all the points, and instead of that, he has to carry around that mic, but maybe he can remember some of them. I've looked at the survey, and I've done a lot of work with surveys, and I think it's really well put together in terms of being very clear and asking very specific questions. So we still have a little more work to do on it, but I'm encouraged, Sally, that it is a pretty good survey and done by a professional. Yes, but it will be modified in the approach. The thing I like about this survey is it focuses on the components. So it really is not asking a lot of open-end, broad questions. It's focusing very specifically on the components. So what will be important is for the residents to understand the components. And we will have, as we said earlier, rebroadcasts of this presentation. So that will be one thing that people can take advantage of. And the other thing is this one-to-one sort of help that the advisory committee, many members have signed up to say, I'll help with that. So, you know, I think that we're going to work as hard as we can to present this in a meaningful way to each person so they understand what they're answering and can fill in a response.
I have a question, Jane.
Yeah.
Hi, I have a couple of questions, actually. What I'm hearing is really good. I like a lot of it. And I think I can see them running around and doing the work that they want to do, and the students and the benefits that we can have. One of the things I'm wondering about is, right from the beginning, actually the relationship that will be between the UW and Capitol Lakes, what will be our responsibilities, who, if there is any problems or concerns, is going to be the person or entity that speaks for it. That's one thing, and that is some of the nitty-gritty that I think before any program goes, you have to work it out somewhat. And the other thing, I'm not concerned, but I'm wondering, has there been any input at all from Capitol Lakes staff in any of these areas that would be affected as to this point?
Well, Dr. Hamrick was involved in the first initiative. I think that there is more to be done. I'm taking your second question first. I think there's more to be done with the Wellness Center staff. They are already doing some initiatives on their own in terms of filling health gaps, and we need to be sure they're integrated. There are a few things that I don't think we emphasized enough in our presentations that, for instance, the Connections Group, Dick mentioned those, but they're doing a very good job in terms of working with the health directives and trying to get that shaped up a little more and meeting specific aspects that are needed to be dealt with on that. And I think that Tim, of course, is involved. So I think that we certainly intend to work with staff. I mean, the staff are our lifeblood around here, and they've been very helpful in a number of ways. They helped us publicize this by the elevator posters, and, you know, they're aware and helping. When we get to the nutrition aspects, we'll have to work with the dietary staff, you know, to see what's feasible, what isn't feasible in terms of recommendations. Let me jump back to your other question, which had to do with what's the formal relationship with the university and with Capitol Lakes. And we did have a pilot here I think I can say a year before last, maybe it was last year, with the School of Nursing, where students from the School of Nursing came over here, and we found 50 residents to work with a each of the 50 residents had 4 visits from a student nurse. And in preparation for that, we did legal work in terms of what the liability was or wasn't in terms of for the student. And so there's been some groundwork laid on that. Capitol Lakes has, a way of screening volunteers, and so there is some backbone for working with students. We also have an expert on our advisory committee, and that's Marion Beachley, who in her working career worked with School of Engineering. Is that right? Students to place them in internships. So I think that we have some expertise right here, we have some experience right here, and I'm pretty sure that we'll be handling that in a way that's comfortable for everybody.
I think one additional piece is one of the members of our advisory committee is Connie Bacher, who is as president of Clara, sits on the Capitol Lakes Inc. board. So there's a connection for that. So that's being attended to. I'm not sure that that everything's ironed out at this point, but it's in the pot.
And I'll just add, I'm actually the assistant dean for experiential education, so I'm the one who's placing the pharmacy students, so there's another connection there. So.
Hi. I'm just wondering, what I haven't really heard is, what will this cost? I mean, how much will it cost? I mean, $50,000, given what you presented, what you did blow right out, because and I think what you're trying to do is great. I hope everything comes through, but what's the impact on what it's going to eventually cost the participants? What is it going to mean to the people that are residents here? We need to have that type of information.
Let me start and then give it to Dick.
Could you repeat the sense of the question? I really didn't get the sense of the question.
I beg your pardon?
Could you repeat the question?
The question is, how much is this going to cost, and how are we going to pay for it? And $50,000 is peanuts compared to what we've got in mind here. And that's all true. The point is that we have several guiding principles. One is it's not going to cost residents, and it's not going to cost Capitol Lakes. It's going to be externally funded. Now, external funding is going to start with a small grant we have that's already here in our hands of that seed money. But then after that, we are going to be searching for money. And as a professor who had to search for grant money, I'm kind of familiar with having to do that. You can't do research unless you get the grant. So we're going to be working very hard to look for money. Now, as Dick has pointed out, this couldn't be a better time than to look for money to what we want to do, because there's national goals that we're going to be supporting. Reduce cost of Medicare. There's also a big, strong goal to increase numbers of people used to working with old people, so training grants for people working with our age group, and to say nothing of what people want. I mean, there's a desire to have better living in this type of community, which we're going to have many more of. So I think that there's good odds. Now, Dick has been talking to people that he knows who are in granting agencies and been getting green lights on this has got a good chance. That's what we've got to go on. We can either decide we don't want to try and give up, or we can try to get this money. But there's no plan to have a bill sent to Capitol Lakes and have them pay for it.
Yeah, can you hear me now? As I indicated, this whole thing, except for component 1 and maybe part of 2, is dependent on our getting outside support. And as Jane mentioned, this is a terrific time to get outside support. But to do that, the first thing we have to do is inform these granting agencies as to whether the residents here are interested in the project and willing to participate. And so that's why it's so important that you're here today and we develop a plan to talk to all of the residents here who we can survey and make sure they understand what this is all about so that we can get a high percentage of surveys back so that we can indicate to granting agencies that we have a high level of interest here. If we don't have a high level of interest with the residents, then I think there's no point in expending all of these efforts because it's not going to happen, because we won't be able to get the professors here to supervise students who are necessary to make this a high-quality program.
There's a piece here that hasn't really come up directly. Jane alluded to it when she referred to the nursing school project that was a year or two ago. My experience here in almost 12 years is that people here want to contribute. People want to help. People want to feel useful, and we have a population that's high level, shall we say. And one of the important pieces of all this is that this is an opportunity for us to contribute to not only the education of the different students in the various multidisciplinary professions in relation to geriatrics, but also the possibility of developing a model that can be applied in other areas and even nationally. So I think that the potential for a significant contribution to all of this is, for me, a driving piece of it.
I have just a very small point to make, and probably not very important compared to most of the points coming up. I think the survey is great, but my antenna go up. I think Sally's absolutely right. You have to do all you can to make sure everybody understands what the survey is about. If your plan is to go and talk to everybody, that sounds okay to me. But I have to say that I hope you do not have people fill out that survey while you're there. People need their independence. They need to do it in their own way, and that my antennae are very strong on that. So I fully support the idea of a survey and getting the information out. You will have people who won't return it, but that's their option. In the long run, you may want everybody to return it. It may not happen, but please give them the independence to do it on their own. The other thing is, I would like to have something in the survey, some place where people can say, what do you feel you need in the healthcare area? Because maybe something will come up we haven't thought about. But that's all I have to say.
Can you hear me? I think our mics are running out.
Okay. Well, that's fine. Let's go ahead.
With respect to the survey, number 5, I do not approve of this component. I think that you might learn more if you followed that with an opportunity to say why, because it may be possible very easily to change the vote, that particular vote, through clarification.
I think that's a good point. The survey can help us to expand and clarify points. I think that's an excellent point, Bernie.
Is someone recording these comments or making notes?
It's recorded in the program.
All right, well, I'm just hoping that, that our suggestions are not just going to be loosely out there. I have something that I didn't hear addressed, what I think is a gap in healthcare here that I didn't see addressed in this program, and I don't know if it's appropriate to address it or not, but it's a gap that I experienced. Shortly after I came here, I broke a bone in my foot and I needed to use a wheelchair, I just assumed that I could borrow a wheelchair from this facility for a few weeks. And I was shocked to learn they had no equipment like that for me to borrow. I had to borrow it from a senior center in the community I moved from. And I see a lot of people here have, I don't mean people in this room, but a lot of elderly people have walkers and wheelchairs and other types of equipment. And when they pass on, I wonder what happens to that equipment. I suspect that it is scrapped. A lot of it is scrapped. I know on Craigslist they're for sale, and I don't think anyone is buying them because Medicare pays for them. And I think a lot of Medicare money is wasted on buying new things and scrapping slightly used things that could be reused. So I don't know if that's a consideration here or not, but I'd certainly like to see Capitol Lakes have some kind of, some equipment that people could borrow, at least for short periods of time.
Yeah. Is that,
Jay, we need a mic up here to answer.
yeah.
This is part of what our discussion was last night in terms of, first of all, regarding gaps that each of us experience. What became clear is everybody has their own type of gap, like what you're referring to. Other people have other type of gaps. And there are people who don't see any gaps at all. So I'm hoping that one of the things that will happen with the survey is that people will take a few minutes to describe or make comments or whatever, ask questions on the back of their survey. And I hope we'll be able to communicate that. As part of your question about the equipment, there was a time when you could borrow things. And I don't know what happened to that. But there is in town a place that used to be called wheelchair recycling that you could take your equipment to once you were finished with it. And then if you at some point later needed that piece or a different piece of equipment, a shower chair or whatever, you could get it there at a very, very reasonable price. So that it was recycling all of those things. That agency is still operative. I'm not sure what the name of it is, but it is intended to address exactly what you're talking about so that those things get recycled and not scrapped. But again, in relation to the gaps, everybody has their own experience of what they need and how it affects them not having that particular need met. So I hope that that's one of the things that you'll communicate to us. Yes, there will be comments requested on the form.
I'd begin by saying it sounds like a very enthusiastic project we should be enthused about. However, I'm a little startled that there's so little attention being paid to costs. For example, if the 3 apartments in the Heights were converted to this usage, if they rented $3,000 a piece per month, that'd be $100,000 a year that Capitol Lakes would be losing in terms of income. I suspect over a year's operating period, that number would be at least doubled with other incidental costs. I'm not suggesting that's bad even. I'm just saying that I'm startled that we have had so little information about direct and indirect costs resulting from this really positive project.
Let me just respond that Capitol Lakes, being a 105c3, can directly receive the foundation grants. And with that, hopefully there will be some overhead. The overhead would not go to the University of Wisconsin, it would go to Capital Lakes, because the grant would be directly to Capital Lakes. UW will not be involved in being the recipient for any of the grants. The faculty who work here, their Capital Lakes would reimburse their department for their salary for their time. Okay? So that we're hopeful that we can generate some indirect costs. Now, as you know, indirect costs for universities are enormous. The University of Wisconsin has an indirect cost level, I think it's 60% now on NIH grants. 60% of the total, over and above the total amount for an NIH grant, goes to the Hill to pay the English department. And so that the overhead is enormous for the university for their grants. But I hope that the foundations will have much less overhead, but that which there is, I hope would go to Capital Lakes. And one thing that we have said that there is no way that Capital Lakes can undergo any financial responsibility for this without increasing your monthly fees, and we don't want to do that.
Are there people living in those apartments, is the question.
Jay, question over here.
Thank you, Jim. That's a really important point. And I assume, Dick, what you referred to was a joke about the English department. Really, a big joke, because they would be surprised to hear that.
Yeah.
So my question is about these apartments that are going to be transformed into office space, and of course, physical office space is needed, even though we supposedly live in a paperless society and everything is virtual, which it really isn't. However, I am really hoping that those apartments that are being made available to this worthy project are not the guest apartments which residents rely upon.
No, they're not. Okay, let me address that. There right now, there are, and you know, I think that Carol can speak to that. She knows what's going on.
I live on the apartments that are in question are on the second floor of the Heights. I happen to live on the second floor. There are currently 3 500 square foot apartments empty and 2 larger apartments. One was Irma Hamilton's and one was Marge Dunham's. And those 2 apartments take 1/4 of the floor. They're on the opposite the Capitol side on the north end. So there's 2 large apartments there that have not been occupied since those 2 people moved out. The 3 500 square foot apartments on the other end of the floor, 2 of them have been empty for several years, and one of them just vacated when Kurt Everson passed away. So my understanding, going back several years, is that there was some talk back then about creating a sort of a step-down assisted living situation where it wouldn't be exactly assisted living, but there would be the possibility for a little bit more attention for people who live there. Just sort of just an intermediate situation between independent and assisted. That just kind of fizzled. And when I asked about that about 3 or 4 years ago, they said, no, they're not thinking about that right now. And they don't have the funds to do any remodeling on that floor. And I was also given to understand that they weren't planning to do anything. There were no plans for those apartments then or even now. So they've been sitting vacant, and I think this would be a great way to use them.
You know, if the committee can just follow up on the guest apartments. You know, we don't want.
No, we're not talking about, the guest apartments are on the sea level, and this isn't going to touch that at all.
Yeah, I think it's, as Carol points out, these apartments are being used for absolutely nothing right now except for storage. And the idea is at some point in the future, when money is becoming available, they might be put together and made into more rentable apartments. So right now, they're totally unused and not usable.
The whole west side of the second floor is not occupied by residents. The only thing in there right now is the art workshop. And the residents on the second floor are all on the Capitol side.
So is that incorrect when it says 2C in the literature?
2C is a misnomer.
Yes,
It's
that's
just
what it's
2.
Well, that's,
Yeah,
yeah, that's it.
right.
Created a
Right, it's C, just scratch C. It's the second floor.
We really apologize for any typos in the manuscript.
Yeah, that's the second time, yeah. Okay, if there are no other questions, we appreciate everybody coming and appreciate your sticking around to learn more. And you'll be hearing hopefully a lot from us in the next couple of weeks. I think today was a good start. And
We'll be up here for a few minutes in case people want to come up and talk to us.
Sure, terrific. And I would urge you to talk to your neighbors who are not here and indicate to them that this will be available. We will have a couple of showings of today's program, probably in the premiere room or someplace in the next week for people who couldn't make it today. And there'll be some of us who will be there to answer questions. So hopefully we can really communicate, and let me urge you to recognize that the members of the advisory committee are all well versed in what's going on, and they're very anxious to talk with everybody.